So chapter 25 talks about oral and maxillofacial surgery. And this starts on page 587 of your dental assisting textbook. And in this chapter, we're going to be describing the scope of oral and maxillofacial surgery. We'll identify the surgical instruments used and describe their function. We'll explain the aseptic procedures followed in the oral surgeon's office. We'll explain surgical procedures, including tray setups and assisting responsibilities. We'll talk about biopsy techniques and list post-operative instructions given to patients. We'll explain post-surgical complications and describe the temporal mandibular joint disease, otherwise known as TMJ. And then also some advanced chairside functions, such as explaining the functions of sutures and when they are placed, as well as the equipment and supplies needed for suture removal. We'll identify the different suture patterns and list the basic criteria for suture removal. And last, we'll explain the steps of removal for identified sutured patients. So to start off with, I just want to identify the oral and maxillofacial surgery, or define it, excuse me. It is the branch of dentistry that focuses on diagnosis and treatment of diseases, injuries, and malformations. This branch of dentistry involves surgery for both functional and aesthetic aspects of disease, injuries, and malformations. To become licensed as a maxillofacial surgeon, a minimum of 4 years postgraduate education is required, including studies of anatomy, anesthesia, pain control, and surgical procedures. The oral and maxillofacial surgery team consists of a surgeon. They'll give patient examination, diagnosis, teeth extraction, cysts and tumor removal, TMJ treatment, biopsies, emergency reconstructive, and implant surgeries. The receptionist and business staff is the same as a traditional office with more responsibilities for communication and record keeping. The dental assistant will vary by practice, but may include sterilization and room preparation, seating and dismissing patients, pre and post-operative care, and assisting surgeons during procedures. A nurse anesthesiologist or anesthesiologist is responsible for administering anesthesia, maintaining patient vitals during the procedure, supervising post-operative recovery, evaluating a patient, and assisting with record keeping. So this is just a picture of a scalpel setup. Scalpels are used to incise or excise soft tissues. They consist of a handle and a blade, and blades come in a or a variety of different sizes. Retractors are used to keep tissues away from the surgical site, which allows a surgeon to have an unobstructed view of the surgical area. Tissue retractors move tissue away during the procedure. Cheek and lip retractors move the cheeks and lips away from the site, and tongue retractors move the tongue away from the surgical site. These are just some pictures of some common tissue retractors that are available. Here we have a tongue retractor to the left and a pair of cheek retractors to the right. Mouth props are used to prevent the patient's mouth from closing during the surgery, and there are a variety of types of mouth props ranging in size from child to adult. Mouth props are made of hard rubber, silicone, plastic, styrofoam, or stainless steel. Some of the mouth props are disposable, such as the styrofoam types. There is a specific kind of mouth prop, which is the one shown here. This is known as the molt mouth prop, the molt mouth gag, which is hinged and has a ratchet release and beaks that kind of keep the mouth open. A hemostat is a forceps with working ends that are not sharp, but are long with serrated or grooved beaks. They have locking handles and can be manipulated with one hand. They are available in various sizes, and they are used to retract tissue, to remove small root tips, to clamp blood vessels, and to grasp loose objects. The needle holder is a type of forceps with a straight beak that is shorter than a hemostat. They are also available in various sizes. Surgical scissors are used to cut sutures and to trim soft tissue. They come in various shapes and sizes. They should only be used for surgical procedures to maintain their sharp edges. Surgical aspirating tips are long, tapered tubes used to remove blood and debris from the surgical site through suction. Surgical curettes are used for curettage and debridement of the tooth socket of the diseased tissue, and they come in various sizes. Surgical chisels are used to remove or shape bone, and they can be used alone or with a surgical mallet. The surgical bone file is used to smooth the edges of alveolar bone. They smooth and trim the bone after the tooth extraction. Rongeurs are hinged forceps used to trim and shape the alveolar bone after the extractions. They are available in a variety of shapes and sizes. Periosteal elevators are used to detach the periosteum and gingival tissues from around the tooth prior to the use of extraction forceps. They are also used to lift the mucoperiosteum from the bone. Elevators have T-shaped handles that allow the surgeon to achieve a firm grip and exert the proper amount of force. There are a variety of types and styles, including apical elevators and root tip elevators, also known as root tip picks. So these are just some examples of extraction elevators. And these little things are root tip picks. So if we have some teeth or roots that were remaining after a tooth broke or an extraction that didn't go well, sometimes we need to use these little guys to take the rest of the root tips out of the socket. Extraction forceps are used to remove the teeth from the alveolar bone. These are hinged with various handles and beak styles. Specific forceps are designed to be used on specific teeth and on the right or left side of the oral cavity. Which instrument is used to detach the periosteum and gingival tissues from around the tooth? This was the periosteal elevator. Asepsis is critical in surgical dentistry. The risk for exposure to blood and opens is higher in surgery, and extreme care should be taken with cleaning, disinfecting, and sterilizing equipment and treatment rooms. OSHA standards must be followed. So these are just some considerations that you will need to take with certain patients. So if a patient is a candidate for oral surgery, it is important to carefully review a complete medical and dental history. Factors may come up during this review that may impact decisions made about the surgery. Radiographs may be taken or reviewed as well. These may be these may be intraoral or extraoral radiographs. Once all diagnostic data has been reviewed, treatment options are discussed with the patient. The patient will determine what option he or she would like to pursue and will provide consent for the procedure. A release form is signed indicating that the patient understands the procedure and is aware of possible complications. Insurance information also should be carefully considered with updates maintained. With oral surgery procedures, including uncomplicated extractions, this involves the removal of permanent or primary teeth that have erupted into the oral cavity. The crown of the tooth will be extracted. The crown of the tooth to be extracted is generally intact, allowing adequate surface area for forceps to grasp. Sutures are usually not required here, and instrumentation is minimal. And here we have a setup for a simple extraction. We have our surgical suction tip, our anesthetic, mouth mirror, periosteal elevators, a set of straight elevators, specific forceps for the tooth to be extracted. We have surgical scissors, rongiers, looks like a surgical curette. We have hemostats, and looks like these are suture scissors, a package of sutures. We will have a Minnesota, which is that tongue-in-cheek retractor, and then a bite block that fits that patient, as well as some dry gauze. With multiple extractions and alveoloplasty, alveoloplasty is when the soft edges or points of the tissues are smoothed away from the alveolar ridge to assure comfort of the new removable prosthetic. So roughness from the bone after having an extraction and possibly a denture fitting over is like having a pebble in your shoe. It creates discomfort and may cause complications with the tissue. The edentulous ridge is contoured for a partial or for a full denture. And then this is an example of a multiple extraction setup where we'll have a Luer lock syringe to the left, as well as which is filled with some saline solution, periosteo elevators, straight elevators. We have extraction forceps, surgical rongeurs, a local anesthetic setup, tissue retractors. Looks like we have a bone file here, root tip picks if necessary, surgical scissors, HVE, surgical HVE, hemostat. We have a mouth mirror, scalpel and blades, which are somewhere here. Here they are. And then at the top of the tray, we have some gauze, sponges, a low-speed handpiece, and with the surgical retractors for the tongue and cheeks, and a suture setup here. So with extractions of impacted teeth, this is one of the most common procedures performed by the oral surgeon. It typically involves the third molars or wisdom teeth. Often the crown of the tooth is not visible, and it is more difficult for the forceps to have something to grab onto. So this is just going over some problems caused by impacted wisdom teeth. All the way to the left, we have the wisdom tooth, which is, they are indicating in this as tooth number 3. Just to be clear, this don't get this confused with the actual tooth numbering system. This isn't part of that. This is just part of this example that they're giving. So this here we have this tooth number 3 here. The wisdom teeth will develop inside the bone. The crowns will form first, and then the roots. So if the jaw grows long enough, the wisdom teeth have room to erupt, and then they can be used normally. And here we wouldn't have to take the wisdom teeth out. But like most cases, if the jaw is not long enough, by age 16, sometimes 18, the wisdom teeth may stay trapped. Here we have the jaw not long enough, so the wisdom teeth try to grow in at this funny angle, and they trap themselves by kind of impacting that tooth number 2. So this happens inside the bone. Over time, there can be infection of gums over or around them. That infection or inflammation of the gums can be very painful. We call this condition periocoronitis, and is one of the first markers to there being an issue with wisdom teeth. Sometimes there can be an infection in the bone around them. That infection can eat away at the bone, which is going to be supporting this tooth number 2, which is a functional, healthy tooth we don't want to lose. That bone loss can actually cause this tooth number 2 to become mobile and unstable if that tooth number 3 is not removed. Also, the destruction of the next tooth, which is tooth number 2, can happen because tooth number 3 will actually impact into tooth number 2, causing the root structure or the nerve structure in tooth number 2 to fail. So these are some of the things that can happen. That patient can actually end up losing both teeth if they don't remove that tooth number 3. So like I kind of discussed earlier, there could be destruction of the bone around the tooth and even the formation of a cyst is possible. And then also crowding. So looking down on the biting surfaces of the lower teeth, we see lots of crowding or misalignment. And that's because we have these back teeth that are pushing, causing a domino effect and making all the other teeth become misaligned. So when we remove a bony impacted tooth, this is kind of the process. Sometimes handpiece and surgical burrs are required to gain access. So starting with letter A, there will be an incision of the gum tissue. The gum tissue will be flapped back using some type of tissue retractor. They will then use hand pieces and burrs to cut away all of this bone so that the head of the tooth is exposed. During that process, there will be irrigation happening, making sure to keep the area irrigated and also to lessen the chances of infection later. So once we have the tooth exposed from the gum tissue and the bone that was around it before, we can now elevate that tooth out for the most part and get it out of there. Once the tooth is out, all the tissue that was cut before is sutured back up, and the patient is allowed to heal. So sometimes we have to, one of the jobs of the oral surgeon is to detect cancer and other oral abnormalities. And they can be done with a couple of different instruments. There is a Visalite, which is just a high intensity light that is used. Here, diseased soft tissue will naturally fluoresce differently from healthy tissue under the blue light spectrum. The Visalite system also allows a dental professional to mark the affected area as well as identify it. With the Veloscope system, they use that blue spectrum light to identify diseased tissue, much like the Visalite. It's just a different type of brown, different type of technology, but very similar in the way that they detect disease. Biopsy procedures are also something that an oral surgeon will do. This is when we have the total or partial removal of tissue from the suspicious areas for microscopic examination and diagnosis. So there are three types. There is excisional, incisional, and exfoliative. So the dentist will examine every patient for abnormal tissue, and when it's found, a biopsy will be performed. The tissue will then be examined for any malignancies. And just note that early detection can save lives. So it's important that we, as dental professionals, do oral cancer screening regularly along with any other exam. So with an incisional biopsy, there is a removal of a small section of the lesion as well as a small border of normal tissue. These are usually done when the lesions are larger than 1 centimeter. So this is the procedure of choice when total removal may impair the patient's appearance and their function. Excisional biopsy is the complete removal of the lesion, including the border of the normal tissue to make sure that all of the abnormal lesion had been removed. This is usually performed on smaller lesions, and this is the procedure of choice when, like I said, the lesion is smaller than 1 millimeter or 1 centimeter. And it is usually done when there is no interferences of appearance and function will occur normally. An exfoliative cytology is also known as a smear biopsy. This is a non-surgical procedure and includes the removal of a layer of cells from the surface of lesion. This procedure involves a removal of abnormal cells, and the cells are spread on a glass slab for a microscopic inspection, and this may be a first step before additional biopsy or removal techniques are performed. Postoperative patient care is very important. It should be given verbally and written. It lists expectations of what to do and what to avoid. So following surgery, it is important for the patient to follow postoperative instructions. The patient should have someone with them for 24 hours after the surgery in the event any complications may occur. Discomfort, swelling, bleeding, difficulty opening the mouth, sore throat, and earaches are common conditions to expect after the surgery. The patient should begin taking pain medications before the anesthetic wears off. Apply an ice pack to ease swelling, apply pressure to control bleeding, eat only soft foods for 24 hours, take medications to prevent infections, brush and floss areas not involved in surgery, and keep with and sleep with the head elevated to reduce swelling, avoid vigorous exercise, and rest for several days following the surgery. The patient should avoid strenuous activity for 48 hours, and sucking, spitting, smoking, chewing gum, um, driving, drinking alcohol, or operating machinery should not be done until after this anesthetic wears off for 24 hours. The patient should not rinse vigorously for 48 hours, and in some states, such as California, a registered dental assistant can place post extraction dressings. Sometimes we have post-surgical complications. Alveolar osteitis, also known as dry socket, is one of the most common complications. This occurs when the extraction site fails to clot properly. Um, the signs of a dry socket are extreme pain, foul breath, foul taste, and exposed bone. So this may be a result of inefficient blood supply, infection, or trauma, and it usually occurs 3 to 5 days following the surgery. To treat a dry socket, we will apply a topical antiseptic to prevent infection, and then soothe the nerve endings in the exposed bone using iodoform gauze, and prevent food from becoming lodged in the womb by rinsing out gently with warm salt water. So here is a tray set up for the treatment of alveolitis. Here we have some surgical scissors here, a curette to dislodge anything that may have become infected, irrigating syringe with the warm sterile saline solution, and iodoform gauze or sponge, which will soothe the dry socket. Paresthesia is the bruising of the nerve or nerve damage, and it can create numbness of the tongue, lip, or chin. It is usually temporary, but sometimes can last several hours or even several days. With TMJ disease, this is when we have muscles, bones, and the joints of the mandible that fail to function properly. And it can be caused by trauma, clenching or grinding of the teeth, or arthritis. And usually we have this, here is a close-up of the TMJ joint or the temporal mandibular joint itself. And as you can see, we have this little, it's a disc that kind of cushions the joint. So some signs of symptoms of TMJ are pain around the ear, tenderness of masticatory muscles, popping and clicking noise when opening and closing the mouth. These are just some common symptoms of TMJ, and after a while they can be debilitating, especially when they are severe. Other signs and symptoms include crepitus or tinnitus, which is that ringing or clicking in the ear, limited movement of the mandible, trismus, which is like an overreaction of the nerve muscle, or excuse me, of the muscle that causes the mouth to close. Oftentimes this is accompanied by a lockjaw or the inability to open fully. Also causes headaches or neck aches in people with TMJ. So diagnosing TMJ disease includes obtaining a full dental and medical history. The joint will be examined, radiographs will be examined, and sometimes dental study casts or study models will be made to figure out why there is that discomfort. So there are a variety of methods used to diagnose TMJ, and it's important to have both a medical and dental examination to correctly diagnose TMJ. So Other treatment includes application of ice and heat, learning how to rest the jaw, medications that will help with muscle relaxation, muscle relaxing, stress management, and physical therapy. Some treatment also includes occlusal splinting, like things like bite guards or night guards, orthodontics to create any alignments that might be causing a bad bite. We can do arthrocentesis is another treatment where we do surgery to the actual disc that is supposed to be cushioning that joint, and then open joint surgery. So there are different things that can be done for arthroplasty. One is a disc repositioning. I'm going to show you this picture again. That disc that I was talking about sometimes becomes misaligned or ends up not in the correct place to provide the most cushion. And with disc repositioning, the disc is basically repositioned so that it's in the correct place and then it's stitched into place. With a discectomy, the disc is surgically removed, and then the hope is that scar tissue will eventually fill the joint and cushion it. An articular eminence recontouring is when the eminence is shortened and smooth to improve the range of motion. And TMJ replacement is the last resort surgery. So TMJ replacement can be either partial or total, using either a prosthesis or bone from another part of the body. This surgery eliminates the need for a disc. However, like any joint replacement, the patient will have certain restrictions and will need to adjust both lifestyle and behavior to reduce stress on the TMJ. Some dental surgeries are best completed in a hospital, which may include traumatic injuries in which time is of the essence in saving or retaining function. Patients with high-risk conditions that must require monitoring or vital signs throughout the procedure. Patients for whom complications requiring additional interventions are high. Patients with disabilities, either physical or mental, who are best handled with the specialized equipment the hospital offers. Patients who need extensive surgery and require additional monitoring throughout the procedure. Some advanced chairside functions include suture removal. Sutures are used to hold tissues in place that has been displaced or incised. The dental assistant here should prepare the patient and equipment for the procedure. Ask the patient if there have been any issues or concerns regarding the sutures. Examine the suture site for the location of the sutures, the number of sutures, the type of pattern that the sutures were placed in, and the healing of the tissues around the sutures. If there is any cause for concern, consult with the dentist on the best way or the best approach to take. When removing sutures, be sure to take care not to infect the site or disturb the healing process. Control any bleeding that may occur with pressure using a gauze pad. So there are a variety of suture patterns that can be used to close an open wound site. The simple suture is the most common and can be placed in most areas of the mouth. The continuous simple suture is placed where there are multiple extractions. The sling suture is used for interproximal suturing. The continuous sling suture is placed where a large flap involving several teeth have been used, and the mattress suture is used when a flap is to be sutured. So what is the most common complication following the extraction of a tooth? So this is alveolitis or dry socket. And if we want to know how to go about fixing something like that, or providing some type of relief for the patient that has dry socket, there is actually a procedure in your book that you can look or take a look at. It is actually procedure 25-6. And it just kind of goes through all the different things that you'll need, as well as the steps required to treat dry socket. That's everything I have for chapter 25. Please let me know if you have any questions. Thanks for listening.